So we'll talk a little bit about electrolytes. When we're looking at electrolytes, we have to remember there's two different fluids that we're monitoring the electrolytes. So we have our plasma fluid or our extracellular fluid, and the main electrolyte in that is our sodium. So sodium is the cation and chloride is your anion. So your positively charged and your negatively charged ions. Inside the cell or in the intracellular fluid, then our major cation is the potassium. The other electrolytes that we'll talk a little bit about is going to be calcium, magnesium, and phosphorus. So the things to remember is that as there is one imbalance to the electrolytes, it generally causes a few different electrolyte imbalances. So if we see a patient that, say, had a prolonged nasogastric suctioning, not only are they losing their sodium, but they're also losing their potassium and their hydrogen and their chloride. So we can alter all of the electrolytes with some of these illnesses. So the first one that I want to look at is sodium. And so sodium, our normal range, 135 to 145 millimoles per liter. Like I said, it is your most abundant positively charged electrolyte outside of the cell, and the functions are to regulate the osmolality, and that is because where sodium is, water wants to follow. So if we have a high sodium, water wants to follow that. It can also be used for conduction of nerve impulses, acid-base balance. It participates in your cellular chemical reactions as well as your membrane transport. Generally speaking, Canadians don't have trouble keeping their sodium content up, and it's because sodium is salt and it's high in our diets, especially around processed foods or flavoring or any type of canned or processed foods are high in salt content. But sometimes we can see a hyponatremia, and generally it's related to excessive nausea, vomiting, or excessive nasogastric suctioning. Or in some cases, it can be from excess water intake. So there are a few conditions where a patient may drink too much water and that drops their sodium. So that's something to be aware of. So hyponatremia is where we have a sodium content in that extracellular fluid of less than 135 millimoles per liter. It can be from dietary measures that are inadequate, but quite often it's from large amounts of nausea, vomiting, nasogastric suction, those types of things, or like I said, excess water, or an IV of hypotonic fluid that's run too fast. So say for a postoperative patient that has had decreased renal output, we may increase their blood pressure by running IV fluids, and so that can lower the salt of that serum. It could also show up in patients that have renal failure, or in patients that have that syndrome of inappropriate antidiuretic hormone, and we've talked a little bit about that in the past. So if it is mildly low, then the treatment may be with an oral sodium chloride additive. So there is a tablet that patients can take, or it could be a fluid restriction, or it could be both. If it is severe, though, you might see the doctor order some small amounts of a hypertonic saline solution. And if you are using a hypertonic saline solution, that can cause a serious fluid shift. So we have to watch those patients very closely. So hyponatremia causes cellular swelling, right? So the low sodium in the extracellular fluid, the water wants to follow the salt into the cells, so it causes the cells to swell, and the swelling of the cells is what leads to that change in mentation or the level of consciousness confusion, those types of things. So remember, sodium is your electrolyte for the brain. So when we have that cellular swelling, it can lead to confusion. So low sodium causes cellular swelling. So let's take a look at hypernatremia, and that is where your serum sodium is greater than 145 millimoles per liter, and that causes cellular shrinkage. So when we've got high sodium in the extracellular fluid, the fluid inside the cell, though, like think of water wanting to follow salt, the fluid inside the cell leaves the cell to be in the extracellular space. So hypernatremia causes cellular shrinkage. So the causes can be from water loss or from sodium gain. And again, the treatment would be to correct the underlying cause. So if the primary cause was from water loss, then it would be a fluid replacement, either IV or PO. If it was IV, it would be an isotonic solution. And again, because we're changing those cells, the fluid inside the cell, we would want to do it slowly so that we don't aggravate their confusion. So serum sodium, we want to reduce it gradually to prevent too rapid of a fluid shift back into the cell, because that could lead to cerebral edema. So besides restricting sodium intake, we could also reduce the sodium by using diuretics. So you might see a patient being offered diuretics to help reduce that sodium. The next electrolyte I want to talk about is potassium. So again, we're measuring the potassium in our extracellular fluid, and our normal range would be 3.5 to 5 millimoles per liter. And it is necessary for transmission and conduction of your nerve and muscle impulses, for cellular growth, and for maintenance of our cardiac rhythms, as well as acid-base balance. So think of potassium as being your cardiac electrolyte. So what happens if we have too much potassium? Hyperkalemia is greater than 5 millimoles, and it can be caused from massive intake. Now, one thing about replacing sodium in the diet, some of the sodium replacements are potassium. So keep that in mind, like at Mrs. Dash, you tell a patient to stop sodium, they trade for Mrs. Dash, which is low in sodium, but they've substituted that sodium for potassium. So if they have had a massive intake, then we might see a hyperkalemia. If our kidneys aren't working, then we may not excrete the potassium, and so that's a common cause of hyperkalemia as well. Or we see a shift from our intercellular fluid to our extracellular fluid, and that could happen in cellular damage. So when when cells burst, they release their content, and remember, our intercellular fluid is high in potassium. So anytime that we see something like rhabdomyolysis or burns or cellular damage, we can see that potassium being released from inside the cell to that extracellular fluid, where it causes some problems, especially with the cardiac electricity. It is more common in patients that have renal failure or like I said, that cellular destruction. And then there are some drugs that can cause a hyperkalemia, and that would be our potassium sparing drugs and our ACE inhibitors. And you probably remember that from other classes. So what do we do about it? So we first want to eliminate the oral and parenteral potassium intake. So monitoring what the patient is eating, making sure that we are monitoring their electrolytes when we have potassium chloride running. We don't want that potassium to go too high too fast. So we need to monitor their electrolytes closely. We can increase the elimination of our potassium by using diuretics, by offering dialysis. So if it is greater than 7, we're seeing patients with some cardiac symptoms, the quickest way to get it down is to do dialysis run to remove that potassium. There's also a medication called sodium polycistrine sulfonate, or K-oxalate. There's a picture of K-oxalate here. It is an oral medication that is given to patients to help them excrete some of their potassium. Now it binds to the potassium and it leaves the body through the GI tract. So we have to make sure that the patient has an active bowels in order to use K-oxalate. So we wouldn't be able to give that to someone that has a paralytic ileus. What else we can also force potassium from the extracellular space into the cells by using IV insulin or sodium bicarbonate. So we've talked about this before. By giving a patient IV insulin, it would be that regular insulin is the only one that we can use IV. We would also give the patient glucose so we don't bottom out their blood sugars, and that would increase the potassium pump from the extracellular to put potassium back into the cells. Now again, that is a temporary shift because the body is naturally going to let that potassium move, and so our best is to get that potassium down by excreting it, but we can temporarily drop a potassium by moving it into a cell. The other one that's not listed here that we've talked about is using Ventolin. So by using a short-acting beta agonist, we can increase the pump, which will shift potassium into those cells. So that's something that you might run across as well. More common to use IV insulin therapy, though. And then the other thing that might be considered is to use calcium gluconate IV. What that does is it helps stabilize the cardiac muscles so that the heart isn't as sensitive to that high potassium. So it doesn't reduce the potassium so much as it does helps stabilize those cardiac cells so they aren't as excitable with that elevated potassium, so that we may not stop the heart as easily. So remember, potassium is our heart electrolyte. So of course, if we have hypokalemia that's less than 3.0, we're going to need to offer some sort of a potassium supplement. And so they can be oral, they can be IV, there's extended release. So Slow K is a potassium that's an extended release. There is IV potassium, either potassium chloride or potassium acetate. For every millimole, it is a milli equivalent. So you might hear a doctor order it as a millimole or as a milli equivalent. If we are giving IV potassium, we have to give it fairly slowly, because if we raise it too high, we're going to cause problems. So the rule is that if we're using IV potassium, we can only infuse 10 millimoles an hour. So we don't want to run it higher than 10 millimoles per hour, and that's to prevent a hyperkalemia and a cardiac arrest. Now, in places where there is cardiac monitors in a tertiary care setting, they can run higher rates of potassium, but on a unit without a cardiac monitor, the maximum rate would be that 10 millimoles per hour. Like I said, otherwise it needs a continuous EKG monitor. So contraindicated would be our patients with renal disease. Again, they would tend to be hyperkalemic, so we wouldn't want to aggravate that. And if they had a severe hemolytic disease where you're having a lysis of a cell that would be a contraindicated because the potassium is being released out of those cells. So we want to make sure that those patients aren't getting potassium supplements.